Okay, welcome everybody to today's webinar presented by the Institute for Health Technology Transformation and Zincs Health, and featuring Dr. Charles Frazier, Vice President Clinical Innovation with Riverside Health System, Robyn Gohsman, Special Projects Coordinator with Riverside Health System, and finally Michelle Norton, Director of Product Strategy and Marketing with Zincs Health. My name is Matthew Rayner, and I am the Senior Marketing Manager here with the Institute for Health Technology Transformation, and I apologize for the cold I'm dealing with and the slightly altered sound to my voice. We here at the Institute would like to thank everyone for attending today's webinar. Here at the Institute, we strive to provide programs such as today's webinar that drive innovation, educate, and provide a critical understanding of how technology applications, solutions, and devices can improve the quality, safety, and efficiency of healthcare. We encourage you to visit our website at www.iHealthTran.com to learn more. Today's webinar will be recorded and made available for download along with the PowerPoint slides on the Institute's website. Once again, that URL, www.iHealthTran.com, by close of business today. We will also be hosting a brief question and answer session at the conclusion of today's presentation. So please feel free to send in your questions at any point during today's presentation by locating the question section on your GoToWebinar toolbar, simply typing in your question in the provided box. At this time, I would like to turn things over to Michelle Norton with Zincs Health. Michelle?
Great, thanks, Matt. On behalf of Zincs, I just wanted to welcome all of you to today's webinar. We have a very important and timely topic today as our speakers from Riverside Health Systems talk about their innovative initiatives with leveraging clinical decision support, not just within their inpatient facility, but really broadening that across the care continuum. And in doing so, hopefully all of you listening today will get some key takeaways and lessons learned on how to leverage that clinical decision support in preparing for accountable care and the emerging care models that all healthcare organizations are faced with today. So we're excited to have everybody. We have a very large group. And so with that being said, I will turn it over to Dr. Frazier since we have lots of great content to cover. Thanks, Dr. Frazier.
Thank you, Michelle. Thank you, Matt. I appreciate it. Robyn and I both appreciate the opportunity to share with all of you folks a little bit of what we're doing here at Riverside. We were just commenting, it's definitely a journey, and we feel like we're just at the beginning of the journey, but hopefully there may be a few things that we are doing that folks can take some useful information away from as we talk about this and share it with you. So. On the next slide, we have a couple of objectives that we've listed. We want to demonstrate to you how we're starting to use evidence-based information in our ambulatory clinical pathways, as well as our computerized provider order entry, as well as what we call IPOCs, or interdisciplinary plans of care in the hospital, to improve care across the continuum of the care that we're providing. And we believe that this approach of applying this evidence-based medicine across the continuum can help prepare us for some of the reform initiatives that are coming along, like value-based purchasing and accountable care organizations. On the next slide, we've got a picture of our largest hospital, is Riverside Regional Medical Center. And Matt, if you'll go ahead to slide number 4, I'll explain just a little bit about our health system and how we're set up. That's the Hampton Roads Specialty Hospital there, but we just put that in there because it's a nice place on Hampton Roads down by the water. But on slide 4, I'll just give you a little bit of background on Riverside Health System and what we're comprised of. At the present time, we have 4 acute care hospitals spread out across Eastern Virginia, and we have a 5th hospital that's slated to be open in January up in Williamsburg, Virginia. We have a behavioral medicine hospital, we have a rehab hospital, we have a long-term acute care hospital, and we have a fairly large lifelong health component which has multiple skilled nursing facilities, continuing retirement communities, and assisted living facilities, etc. And then we used to say that Riverside Regional was the flagship of our health system, but actually I would say the flagship of our health system now is our medical group. And that's a 500 provider multi-specialty group, again, that's spread out over the eastern part of Virginia. In fact, on slide 5, you'll see on a map there a little bit more geographically how we're spread out. And it is pretty much along the Virginia Peninsula and then what's called the Middle Peninsula and then what's called the Northern Neck, although we do have a hospital out on the eastern shore of Virginia as well. Now, on the next slide, I wanted to talk to you a little bit about the approach we've taken with this. We have a problem. I was going to say we had a problem. I still think we still have it that I'm sure no one on the phone has experienced, and that is across this health system, we've got great people that are looking to solve problems, and what we found out was that people in different parts of the organization at different hospitals, et cetera, would be working feverishly to fix some problem, but it would be the same problem. So, for example, you might have one group out at the Eastern Shore working on reducing readmissions for heart failure, and we had a group at Riverside Regional doing the same thing. We had another group at another hospital, and we realized that there was a lot of duplication of effort, and there were great ideas, but they might not necessarily be the same ideas, and we weren't necessarily sharing some of those same good ideas. So we actually made an effort to try to survey what we were doing across the organization and to try to coordinate those efforts and to focus what we were doing to try to get more impact from our efforts. On the next slide, you'll notice a diagram that kind of looked at our approach to that, and we wanted to look at, and this is basically just the continuum of care. We wanted to look at what we're doing on the ambulatory side. We wanted to be able to identify any problems early that the patients were having. We wanted to be able, if they had to be admitted, to take care and apply evidence there. We wanted to make sure that we were coordinating transitions from one aspect of care to the other, et cetera, et cetera. And on the next slide, we'll show a little bit what we did with the PC3 project. As I said, we did a survey. We went across the organization, asked folks what they were working on, which initiatives they were working on, and that list on the left-hand side is some idea of the diversity of things that people were working on out there. And we said, okay, that's fine. That's great work. That still needs to continue in some way, but let's focus our efforts at least on a few, and we ended up with 5 different conditions that we were really going to take a coordinated approach at and work across the continuum on these efforts. We looked at such things as the prevalence of conditions, the impact of conditions, the cost of these conditions. We looked at some of the initiatives with some of the national regulatory agencies, and we had kind of a scorecard like that to assess these various things we were working on and come up with this list. And we came up with 5 things: heart failure, COPD, diabetes, venous thromboembolism, and particularly kind of from a patient safety standpoint, the monitoring and appropriate use of anticoagulation, and we wanted to look at hypertension. Hypertension is one, I'm a family physician, hypertension is one I particularly had an interest in because it has such an impact on so many other conditions, including heart failure and diabetes, but also stroke and renal failure, et cetera. So those were the 5 conditions that we decided to work with. On slide 9, you'll see that we started to look at how to approach that across the continuum. And our primary focus, no pun intended, but our primary focus is really in the primary care of these conditions. And we wanted to take evidence and develop pathways for these conditions, and not only develop those pathways, but to embed them into our electronic medical record to make it easier to do what we really need to do with these patients. Having said that, patients still need to get admitted sometimes, so if they are admitted, we wanted to apply the evidence on our order sets in the hospital. We do use electronic medical records throughout the organization, and we wanted computerized provider order entry order sets that were evidence-based, so we developed those. We then started working with the contents from Zincs, the evidence-based content for Zincs, to develop interdisciplinary plans of care, once again embedded into the electronic medical record. And where we are right now is to really start working on developing those into more of a longitudinal plan of care, and so that regardless of where the patient transitions within the care continuum, that we're applying evidence-based medicine to their care. On slide 10, to start the discussion, I wanted to talk to you as one example of what we've done in the primary care office to apply evidence to the care that we're providing. And I'm going to demonstrate to you a diabetes pathway that we've developed, a diabetes management form that's within the electronic medical record where we embed that evidence-based care in there. And I'll show you how we've woven in this evidence that we've taken from Zincs as well as other nationally recognized guidelines, evidence-based guidelines, and again put that into the electronic medical record form. So on the next slide you'll see a screenshot. We considered doing this as a live demonstration, but my experience with that is you're kind of playing with fire. So these are all screenshots, but this is our production system. And although this is a test patient, this is live data that we live content that we have in there right now. This just is a screenshot of the way the electronic medical record looks. We use Centricity from General Electric in their ambulatory practices. And I'm going to show you now the diabetes management form. And if you go to the next slide, this form is designed to be able to make it easy to collect and document the patient's symptoms. So as you can see there, it's easy to document the absence or presence of polydipsia and polyuria, etc. It's easy to document how many times they're checking their sugar per week and what those glucose readings are averaging, et cetera, et cetera. We have certain indicators in there if they're on ACE inhibitors or ARBs or aspirin and those sorts of things. But you'll notice down at the bottom that there's almost a dashboard component to this to make it easy to see that the presence or absence of certain evidence-based indicators, whether it's that they've had their eye exam or their foot check or their pneumovax or whatever, as you can see there. Up at the top you'll notice there's a button that says View Pathway. If you go to the next slide, when you click on that button, it pulls up basically a web page that has interactive content in it, and that you can hover over. There are tool tips, etc., that you can actually go down through the pathway. And Matt, I know you may have changed to slide 13 or 14. If you go ahead and change, there you go. Thank you. And you can see there that we've got this pathway that goes through everything from the diagnosis to diabetes to the importance of setting individual hemoglobin A1C goals to the importance of diabetic teaching, etc. And on the next slide, you'll see that it proceeds to go down to a flow chart that actually talks about hyperglycemia and the approach to controlling that. This view that you're seeing now shows the tool tips, et cetera, that are built in here. You hover over some of those little information circles and these tool tips that come up, and some of them are active, so if you click on them, it'll actually go to the evidence. Some of them are best practices that we've set up that, for example, down where it says get labs prior to visit, if you hit on that little BP icon, it actually gives a story of how one of our practices set it up so that you get easily and reliably and consistently get labs prior to the visit. On slide 15, again, you can see the flow chart and how it continues on for the management of hypoglycemia. And as you might imagine, it breaks it down in well-controlled patients versus not well-controlled. And again, we've embedded this pathway into the electronic medical record. On slide 16, again, you see that form. And up at the top, you might notice that you have these other tabs up there. And on the next slide, you'll see if we hit that button that says, or the tab up top that says glycemic control, then these are the pharmacologic agents that the patient already are on, and these are classifications of medications that you would typically go through, and generally the kind of the stepwise approach you might take to add medicines to a patient to get them under glycemic control. That varies, of course, depending on the patient's comorbid conditions and other factors, but generally this would be, at least in the pathway that we set up, the kind of the approach that you would take. You'll notice that beside two of those classifications, Matt, if you could go back up to that slide, I'm sorry. You'll notice that beside two of those classifications, there are check boxes there. This patient is already on metformin and a sulfonylurea. If I wanted to add another class, let's say I wanted to add the DPP-4 inhibitor, there are two buttons there, one to prescribe it and one to get more information about it. On the next slide, you'll see if I hit that little I button for the information, it's a very concise description of that class of drugs. That's taken verbatim out of that source there, which is an American Diabetes Association publication. As well as there's a link there if you wanted to drill down and get more evidence on DPP-4 inhibitors from zinc. You could click the link there and pull that up. We realize that physicians may not have the time or take the time to look at this information while they're seeing patients, but they can if they want to, and it's certainly there for them to look at any time if they need to. On the next slide, excuse me. On the next slide, you'll see that same form there, and if you were to hit the prescribe button, on the next slide you'd see actually what would happen there. When you hit the prescribe button, you actually, for the DPP-4s, for example, you get this custom list of those types of drugs in typical starting dosages, and all you'd have to do is pick the dosage and the formulation that you want, and that's your prescription. You can send it electronically or print it or whatever else you want to do. On the next two slides, you'll see that we have the same sort of setup for lipid control and blood pressure control. And on slide 22, you'll see another tab we have up there that helps us to keep track of the patient education that we've provided to these patients. You'll notice that there are different handouts for diabetes, and over on the right-hand side there are preview and print buttons. And basically, if you go to print one of these patient education handouts, it automatically puts in the date that the patient was given that, and it makes it easy for the provider to look down and see what the patient has been given and when they gave it. And our general approach to this is we like to work through these in a cycle and give these patients, different patient education as time goes on. And if they're a long-standing patient, we may have given all this information to them, but by knowing when we gave it to them, we can cycle back through and not keep giving them the same information over and over again. On the next slide, I want to talk to you a little bit about something we call the SMART plan. One of the things we noticed early on in the PC3 initiative, Patient-Centered Care Coordination Initiative, is that each of these specific disease entities, one of the kind of best practices is that you give the patient a written plan of care. And it occurred to me one day as I was sitting in one of these meetings that if we gave a patient who had CHF and diabetes and COPD, if we gave them a written care plan for each one of those, we'd be giving them multiple plans of care. They wouldn't be coordinated. We very well might give them different diets. We might give them different targets or whatever. And it seemed to me what we really need to do is try to give a consolidated plan of care. And this is our effort to do this. So we call it the SMART plan. SMART stands for S, self-monitoring. So we put in this plan the things that we recommend that the patient monitor themselves, and it could be anything from monitoring their blood sugars if they're diabetic to monitoring their weight if they're a heart failure patient, to monitoring their peak expiratory flow rates if they're an asthma patient. Whatever it is, we put that in the self-monitoring box. M stands for medications, and that's just the reconcile medication list. A stands for activity/diet. We couldn't quite figure out where to put the D in there, so we just put that together. And so that's a consolidated activity and exercise recommendation and a diet recommendation. Now, I'll have to say usually it's a heart-healthy diet, but whatever it is, it goes in that box. R stands for risk reduction, and those are the things that we're recommending to the patient that we want them to do, or that we advise them to do to reduce their risk. And it could be anything from stopping smoking to losing weight to eliminating environmental triggers for the asthma. Whatever it is, that goes in the risk reduction box. And finally, T is for targets, and those are the hard targets. What would we recommend for them for their hemoglobin A1C? What do we recommend for their blood pressure value, et cetera? Now, it may seem that that's very paternalistic and we're dictating to the patient what these things are. That's not the case at all. This is really meant to be a discussion document, a collaboration document, a negotiation document, and we do collaborate with the patient. So, for example, one of the targets might be their weight. We're not going to necessarily put in whatever their BMI of 25 would be. You know, if they have a whole lot of weight to lose, we might have some intermediate target that we agree upon and say, okay, great, let's make it 25 pounds less than what it is now, what your weight is now. We'll put that in as the initial target. You'll notice some other buttons below there, and those are just documentation buttons to document that we've collaborated with them, to document that we've assessed barriers and addressed those, to document that we've used a teach-back method with the patient to make sure that they understand what we're actually talking about. And I'll talk a little bit more about why we did that, but it was to be able to document that we did those things for our medical home initiative, and to be able to for example, to demonstrate to NCQA that we're actually doing that. On the next page, you'll notice the actual printout from that, and we print out these smart plans and give them to the patient. Again, we log that we've given that to them, and the idea then is that this plan of care, this smart plan, would follow the patient along their ambulatory course, regardless if it's a family medicine physician seeing them or a cardiologist or whatever. So that gives you a little flavor of how we've embedded the evidence-based approach into our electronic medical record, into our clinical pathways on the ambulatory side. I'm going to switch it over to Robyn now. We're going to talk a little bit about what would happen if this patient was admitted to the hospital.
Matt, if you'll please advance to the next slide, please. So the question is, you know, what does happen to this patient, this diabetic patient that's been cared for in one of our RMG practices? You know, 20 years ago, a diabetic patient may have been admitted for their diagnosis of diabetes, but in reality, that just doesn't occur today. So the question, we have to continue to care for that patient, that diabetic patient, as they're admitted to an acute care facility. On the next slide, you'll see we're gonna set up a scenario that this diabetic patient is being admitted to an acute care facility for pneumonia. And in addition to being a diabetic, we're gonna surmise that they are also a smoker. So we need to, one of the things that we've done from an order set perspective, as Dr. Frazier talked about in the beginning, was that, you know, we had several facilities all doing great work, and one of the things that we encountered when we first started to develop order sets was that each one of our facilities typically had their own pneumonia order set. So and we started working on this back in 2008 and 2009. We went live with CPOE in 2009, so a lot of the groundwork was done prior to that. But one of the directives that we were provided was that there will no longer be separate order sets for each facility. There will be one standardized order set that will be used across all acute care facilities. So what you're seeing now is our pneumonia admission order set. And you'll see, if you look over on the left side, there are evidence links that we have embedded within that pneumonia admission order set, just as we have with the majority of our order sets, because we've developed these through Zincs as well. And if you look on the next slide, one of the things that we've tried to do really to help our providers is that within that pneumonia admission order set, we also have our sub-Q insulin order set, which is embedded within the pneumonia order set. This prevents the provider from having to go out of that pneumonia admission order out to another order set to be able to provide care for this diabetic patient. So you'll see, again, the sub-Q insulin order set is embedded within that pneumonia order set. On the next slide, you'll see that we're actually kind of drilling down here, that actually embedded within the sub-Q insulin order set, we also have a hypoglycemia treatment order. So this, again, the idea is that the provider would not have to now go out of the sub-Q insulin order set in order to be able to provide, to access the order for a hypoglycemia. So we're really trying to make it the fewest number of clicks for a physician and really make it user-friendly for them. So again, we have hypoglycemia treatment order is embedded within the sub-Q order, which is embedded within the pneumonia order. Within that hypoglycemia treatment order, on the next slide, you'll see there's actually a hypoglycemia treatment protocol. So this is how we're taking care of our diabetic patients, for instance, that are admitted for pneumonia. This hypoglycemia treatment protocol, currently this is still on paper that the nurses are able to access, and we're working through that just because there are a lot of if this then this type orders here, but it really it's a protocol, an algorithm that the nurse can follow that is pretty straightforward, that if the patient's blood sugar falls below 69 and given the following conditions, this is what they're able to do. If you look on the next slide, this is where the nurse is able to document if the patient were to become hypoglycemic. We're back into Sorian, and this is where they would be able to document what they have done for this patient in regards to their hypoglycemia. On the next slide, one of the things, you'll see nursing admission assessment. And for our nurses, with a patient being admitted, they have up to 8 hours to complete that initial nurse admission assessment. And you'll see what is highlighted there in the middle of the screen is one of the questions is does the patient have a history of diabetes? Yes or no? And you'll see on the next slide, the response to that question, if they do have a history of diabetes, what that triggers is an alert to the physician that there really should be a hemoglobin A1C order placed for this patient, for this diabetic patient. And you'll see the top box there on the left. The question is, there's this hemoglobin A1C alert that comes to the physician. They have the opportunity, and if you were to click on that arrow, which takes you over to the screenshot on the right, when that alert comes up, while they're still within that alert, they have the opportunity that they can go ahead and order that hemoglobin A1C right there while they're within that same screen. If for some reason maybe the physician is aware that the patient has had a hemoglobin A1C maybe 2 weeks ago, and so maybe we don't need to order that again, they have the opportunity, you'll see that's the bottom screen there, that they have the opportunity to document why they're not going to order this hemoglobin A1C for this particular patient. Riverside Regional Medical Center is a Joint Commission certified diabetes center, and these are some of the processes that we have put in place to help reach the goals that we need to have to attain that certification. On the next slide, you'll see this is where the nurses are able to document how they're caring for that diabetic patient. And you'll see over on the left under diabetes care topic taught, there are a variety of topics that the nurse can, either the nurse or the diabetic educator, can go in and speak with the patient about a variety of topics. And then over on the right, this is the documentation that, yes, that education or that discussion has occurred, and it's right there within Sorian. Part of one of the components to the PC3 project is really standardizing, in addition to having, a variety of order sets, a variety of processes, et cetera. We also have discovered that there were a variety of patient education tools that are being used. And so one of the things that we're really looking at from a PC3 perspective is also patient education. Again, from a patient perspective, if a patient was receiving one piece of education while they were in their primary care physician's office, but yet then they received a different piece of education when they were in acute care, you can see how the patient could potentially be overwhelmed, but there's also that possibility that one piece of education may contradict the other. And so one of the other components to PC3 is the standardizing of the patient education that we're providing. If you look on the next slide, keep in mind this is our patient that was admitted for pneumonia. They were not only a diabetic, but they were also a smoker. One of the questions on the nursing admission assessment is around the patient's use of tobacco. And you see there in the highlighted section in the middle of the screen, under tobacco use, they're able to document how many packs a day that they were smoking, etc. What this does, when you look at the next screen, what this does, a positive response to the patient being a smoker, what it does is it will actually trigger, you'll see up there in the highlighted area up in the upper left corner, is it triggers a screen to respiratory care. So what respiratory's goal is that within 8 hours of them receiving that screen, they will actually go and see the patient, have conversation with the patient, begin to educate regarding smoking cessation. So again, within 8 hours, hopefully within 8 hours of admission, respiratory has been there to see that patient. And so as the respiratory talks with that patient, when you look at the next screen, respiratory can then initiate the tobacco use cessation, IPOC, that interdisciplinary plan of care. And you'll see within that highlighted box, there are also, within our plans of care, we also have evidence links so that the end user has that evidence available at their fingertips as well. Just kind of as a side note, when we began to really look to develop our plans of care, traditionally plans of care have been really nursing focused. Excuse me, and one of the things that we really wanted to do is it takes a whole team to care for that patient, and so we've termed our plans of care our interdisciplinary plans of care, respiratory, PT, pharmacy, et cetera. They are all part of this team. So again, respiratory triggers that tobacco use cessation, IPOC. We look at the next page. One of the topics that was brought to our attention as we were developing plans of care was that, we tend to focus really upon what is the physician's goal for this patient while they're within the hospital, what is the nurse's goal for this patient while they're in the hospital, and inevitably, everybody, the big goal is that we want to transition this patient back home or back to their original setting. One of the things that we failed to, previously, that we, Riverside, had failed to do was to really ask the patient, what is your goal? While you're here, what do we need to do in order to be able to help you function the way that you would like once you transition onto your next setting? So if you look at the next slide, one of the things that we've done, and this has been just a huge success for us, is that one of the goals that on every patient has at least one problem / plan of care that's been initiated, and they also, the patient is being asked daily, what is your goal? And we're really working with nurses in particular, because inevitably the patient says, I want to go home. And what we're really encouraging nursing as well as the interdisciplinary team to do is to really start to have a deeper conversation with that patient and say, we understand that you want to go home, but what can we do? What's your goal for today? Since we've started doing that, we have had several catches. For instance, we had one patient had been admitted for, I believe it was for COPD, and so the focus was really on that patient and their COPD and the goals that are associated with that. But the patient, when he was asked, what is your goal, the patient said, I want to be able to walk. Well, he had knee pain that was really preventing him from walking, and if we wouldn't have had that conversation with him, you know, it's very likely that he may have been transitioned to the next care setting still with that knee pain unaddressed. So having that conversation, and we've seen some great successes, which I'll show you here in just a minute with that. But again, what is the patient's goal and or the family's goal as well? You look at the next slide, this really drove us to take a look at patient satisfaction, because now the patient, our idea is that we really want that patient to be a part of that care team. And again, from a patient-centered care coordination perspective, the patient is always at the center of that. So we looked at our Press-Ganey patient satisfaction questions, and we wanted to take a look at those and see how they would align with what we were doing, especially around IPOC and having that patient be involved in their care. And so we took a look at these 3 questions from Press-Ganey, and ultimately the bottom line was we wanted to create a personalized healthcare experience for each and every one of our patients and really get to know their story. When we look at the next slide, these are the results. Again, and we, when we're going live with our interdisciplinary plans of care, we're rolling that out by facility. One of our smaller facilities, Riverside Shore, went live on June 19th. And when you look at, we're just thrilled to pieces with this, that when you look at where they were from the perspective of attention to special and personal needs, in June, Shore was in the 9th percentile. In August, and that's when we have the last data available, but in August, they were up at the 99th percentile, and you can see that they had actually exceeded the mean. When you look at the next slide, again, we're reporting out on our results. Did the patient feel as if they were included in their treatment decisions? Again, they went from the 11th percentile to the 55th percentile. And again, not a significant improvement as you had seen in the previous slide, but yet nonetheless there was improvement there. The last slide, this is regarding the question around the staff working together, and again went from the 16th percentile to the 90th percentile. We're going to continue to monitor this not only for Shore but our other facilities. Actually, our largest facility, Riverside Regional, just went live with interdisciplinary plans of care yesterday. And so what we're doing is we're monitoring these in 3-month increments, and we hope that we continue to see this same trend. If you look at the next slide, again, we talked about when we kicked off this interdisciplinary plan of care, we really, again, wanted to make sure that the patient was in the center of this. And this slide, I think, really provides that visual. It really takes a team to accomplish what we need to accomplish and care for that patient. Obviously, the physician and the nurse play a role in that. But again, the patient is a member of that care team, as is the family. And in that last bullet, team members are working together to execute a plan that meets the goals that have been agreed upon, not only by the patient and the family, but also by the care team. If you look at the next slide, one of the pieces that we are currently working on, we don't have this in production yet, but we are making strides to get there. And I have to say, this is courtesy of Mainline Health, that this is one of the this is what they provide for their patients. What we are going to do is this daily plan of care will be printed off, obviously daily, and provided to either the patient and or the family in most situations. There might be some patients where maybe it will not be the best idea to provide this to them, but we are actually working for this. It will be printed off daily, provided to the patient, and you'll see over on the right side of the screen, especially from a medication perspective, breaking this down into patient-friendly terms so that the patient can see, for instance, if they're on Ativan, that this is typically prescribed to treat anxiety, seizures, nausea, or to help sleep. And many times patients are prescribed medications. They don't necessarily know why they're being prescribed that. One of the other things that we're planning to do is under pending studies. that, for instance, if the patient may have let's say an echo that has been ordered for this afternoon, and maybe this was printed off in the morning, it would be there available when the family comes in. They will see that, oh, mom is not here in her room because, oh, that's right, she had her echo scheduled for 2 o'clock today. If you look at the next slide, this is another component that we're working on. Currently, this is in paper, but we're working on it in Saurian as well. We call it the 5P transition, and this tool would be used anytime a patient is transitioning to the next care setting, so that in a real quick glimpse, the receiving entity could see this is what has been happening with the patient. One of the hurdles that we have right now is that our various components to our health system all have different EMR, electronic medical records, that they're using, and interoperability is one of the hurdles that we're trying to work through. So currently this is on paper, but we're working to make that available in Saurian. The next slide, you'll see this is a copy of the discharge instruction that the patient would receive. What I want to point out about this, you'll see right there up under the Riverside logo, it says share this form with your primary care physician. In addition to that as well, you'll see, I think it's a patient-friendly form that stop signs, green checks, etc. At a quick glance, the patient can see when they're being transitioned from out of the acute care setting onto the next setting, that they can quickly see what it is, which medications they're to stop, which they're to continue, etc. The next slide, and this is Dr. Frazier referenced this earlier, LIPOC, which we refer to, it's LIPOC, it's longitudinal interdisciplinary plans of care. Because one of the things that we're thinking is that when a patient is acute care and we have implemented these plans of care, it's unlikely that the majority of those problems that the acute care team has been working on, that they will be resolved when the patient transitions from the acute care setting, for instance, back to home with home health, or if it's long-term care. And just because the patient is moving from one setting to the next doesn't mean that their problems are going away. So what we're working towards, and in 2013, we will have this live, that we are working that, for instance, when a patient, let's say tobacco cessation, that's the problem that the acute care team has been working on. And when the patient transitions from the acute care setting, let's say to home with home health, then that plan of care that the acute care team has been working on will also move with the patient when they move to the next care setting. And so the receiving entity will be able to see this is what the acute care setting has been doing, and that goes full circle as well, because it may be that home with home health, when they transition back to their primary care physician, that in turn would follow them as well. This is a pretty big undertaking, just because we haven't been able to find other organizations that have necessarily been able to do this. I think there are several that are working on it or thinking about it, but we're determined, and we're going to do that. See, we have determined COPD will be our first interdisciplinary plan of care, LIPOC, that we actually go forward with, just because we have several resources that we can use to hope that we can implement that. And our idea is that once we can get the first 1 or 2 under our belt, that we should be able to duplicate that. In the next slide, you'll see the components of the patient-centered care. Again, we thought at first when we started working on interdisciplinary plans of care, oh, we'll just work on interdisciplinary plans of care. But as we really began to work with this, we realized that the policies and procedures that support those IPOCs, they also needed to be looked at. What is the scope of care? The admission assessment, we essentially, in January, we took a real hard look at our admission assessment the way that it was, and we realized that it wasn't necessarily real meaningful, and some of the information that we were getting out of that wasn't really helping. And so this is really just kind of a snapshot of what our whole project is around patient-centered care. And, it's one of those things when you turn over one rock, you find other things that you need to address, and then you turn over the next rock and you find additional items that you need to address. So in the next slide, we'll turn it over to Dr. Frazier. He's going to talk a little bit about the impact that has been realized.
Well, Robyn already, I think mentioned some of what we think is some impact on some of our patient satisfaction scores in the hospital. And actually, I'm kind of dealing with the same issue here, is that this is still relatively new, and we've got some exciting trends, but we'll have to kind of follow this a little bit more and see how things go. So the slide here just demonstrates a part of our primary care dashboard. We have a dashboard where we have various quality indicators as well as a whole variety, about 50 indicators for a medical home. And but one of them is there on the left-hand side is the diabetes care bundle. We've used a variety of bundles, as we call them, in the past. We had been using for the last few years the D5 bundle, which is our 5 diabetes measures that the patient has to hit all 5 of those to get credit for the bundle. We changed it to a 4-measure bundle this year. We're looking at hemoglobin A1C control, LDL control, whether or not the patient had an eye exam appropriately, and whether or not they've been screened for nephropathy or had their nephropathy addressed. And interestingly, we actually implemented that SMART plan. We've been using the disease management form for a little bit longer than that, but we really pushed on this, using the SMART plan and using it as part of the disease management form that I showed you for diabetes. And we've seen some increase specifically since June that I can't necessarily attribute to that, but something changed in June and things got better for the group. The red line is the group measure, and then the blue line is for this particular practice that I pulled up for this to get this screenshot. And you can see, taking that same kind of approach for some of our screening stuff, the breast cancer screening is improving, the colorectal cancer screening is improving, et cetera. So I think trying to apply the evidence and doing it in a systematic way and putting it in, embedding it in the electronic medical record and having tools available both within the EMR and on this dashboard, I think is starting to have some impact. On the next slide, I just wanted to briefly, and we'll finish up with this, I just wanted to briefly talk about kind of the interest we're seeing in some of these initiatives from some of our payers. They do indeed seem interested in this. The way we're trying to embed the best evidence into our practices, embed it into our electronic medical records, and really apply that to the care of our patients. For example, the SMART plan easily meets NCQA medical home standards for care management and self-management. It also helps support our performance improvement activities there. And the reason I picked that one particularly to talk about is that while getting the NCQA recognition for medical home doesn't mean that you're delivering accountable care, having that sort of approach to the patient is really the basis, I think, for an accountable care organization. You need that kind of approach, that patient-centered approach in the primary care offices to form the foundation for your accountable care organization. And so I would say that these sorts of tools certainly support patient care. They certainly support disease management. They certainly support care coordination. For example, the 5P handoff tool that Robyn showed you. Having these sorts of cares of plan, both in the acute care and in the ambulatory care, spanning that continuum of care, helps in case management. And I believe all of those things, disease management, care coordination, and case management are necessary for accountable care. So again, we are not one of the pioneer ACOs. We're not right now participating in any of the shared savings programs or anything. We are looking at those things. We're having discussions with various payers about it, and I think again some of this activity is setting a good foundation for some of that payment reform. So with that, if you want to go to the next slide, we'd be glad to answer any questions. I know that was a lot of material. I know we kind of flew through it, but we would be glad to answer any questions if anyone has any.
Thank you. And once again, I would like to first remind everyone that today's webinar recording and the PowerPoint presentation will be available on the Institute for Health Technology Transformation's website. Once again, that URL is www.ihealthtran.com by close of business today. As Dr. Frazier mentioned, we would now like to open up the presentation to answering your questions. As a reminder, to submit a question, please click on the Questions tab on your GoToWebinar toolbar. Simply type in your question in the provided chat box. I will now turn things over to Michelle Norton from Zincs Health to conduct today's Q&A session. Michelle?
Great, thank you, and thanks Dr. Frazier and Robyn for the excellent presentation. While we're waiting for folks to send in some questions here, I do have one. I know that towards the end, both Robyn and Dr. Frazier, you both mentioned some different outcomes that you're tracking, both patient satisfaction with some great improvement after the IPOCs were implemented, and then Dr. Frazier, you just discussed the screening utilization of the evidence at the in the practices. But I was wondering if either of you could share a little bit more about some of the quality metrics and outcomes you're tracking around readmission, prevention, or other focus there at Riverside.
Especially with our PC3, our Patient-Centered Care Coordination initiative, we're really tracking readmissions, and we're focusing on everything, but really spending a lot of time on those 5 key conditions that we're looking at. And one of the things that we have noticed is that, at least at Shore, once we went live with IPOC again in June, there was a pretty significant reduction in heart failure readmissions. And granted, it's just we don't really feel like we have statistically significant data yet, but we have seen what we think is a pretty good trend as far as the reduction in readmissions. We also have seen a reduction in adverse events. And again, that's just tracking that from June when Shore went live with the plans of care. But we're hoping that that will continue, and hopefully in another 3 to 6 months, we'll be able to report more definitely out on that.
Great, thank you. And we have a number of questions coming in here. So there's several around the transition form, the care coordination piece you talked about, Robyn. I think you mentioned that form, there's a question on where that resides. Is it within the electronic health record? I know you mentioned that regarding some of the forms, if you can maybe clarify. And then second part to that question is that some of the sites here that are attending organizations are, say they're struggling a little bit with the transition, both within the hospital and at the discharge process. And so anything else you might want to add to that transition piece of key lessons learned or anything they can take away to their implementation?
As I indicated, one of the hurdles that we have right now is with just the interoperability between facilities and different entities. So, for instance, the 5P transition form that I showed, that currently is on paper. We're in the process of building it in Sorian. And the reason for building that within Sorian is that we'll be able to pull that data out of Sorian so it would auto-populate. Today, what's happening is that a lot of that information, or actually all of that information that we're putting on that 5P transition form is being handwritten, and you see the opportunity for error there. So we're getting closer to having that report where we could actually generate it out of Sorian. It would automatically print, and then you could hand that off to the receiving entity. Idea is that this is just a snapshot of when the patient transitions from one, like for instance from the acute care setting, if they were going to a long-term care setting. This is a snapshot of where they are when they're being transitioned. Obviously you would follow up later with the full record, and so that they would have additional information, but this can at least get them started in their next setting.
Great. Thanks for sharing that. And there's several other questions around adoption of the evidence-based order sets, about having provider-specific order sets, and also sort of how that it's difficult enough to get collaboration and consensus around order sets, but also pretty significant, the work you've done around your diabetes protocols and hyperglycemic protocols. So just, I think it was somewhat of a kudos, but also how, what have you seen with adoption and just clinical collaboration around the order sets. I don't know if either one of you want to answer that one.
This is Dr. Frazier. I'll start off, and then actually Robyn is a great one to address that, because she's really been the go-to person, the dynamo behind the scenes. I think she's been able to get folks to come to the table. And actually, one of my colleagues, Dr. Stolle, who's the Vice President of Medical Affairs, he's been instrumental in that as well. A couple things I'll say is that we started off with this process with actually doing order sets on paper using Zinx. I'll have to say Zinx has been a good tool for us because it really facilitates the collaboration and communication. And I'll see if I can do this as briefly as I can. We started setting up these order sets, and what we did was we actually created a physician advisory group, physician advisory committee. We call it the PAC, and we had each facility's med exec committee delegate the authority to that centralized, system-wide PAC to make decisions on the order sets. Robyn then went out, and Dr. Stolle kind of helped crack the whip and got some physician champions in the different specialties to help develop or help scale down or carve down, I guess, the Zinx order sets. And then we used Zinx then to send out those order sets to the various stakeholders and said, hey, you've got 2 weeks to make comments on this, at which point we'll take it to the PAC for approval. So that's what we did. If they didn't make comments on it, then that's how the order set got implemented. And then the PAC would then take and make the final decision on that. And again, that authority was delegated by each med exec committee so that we meet Joint Commission standards. What we found was that while we started doing that on paper, because on paper you can just write in additional orders, when we actually took those same order sets and put them into CPOE, we found fairly quickly that there were some other orders that needed to be added to those order sets. So one of the things we had kind of lucked into, and I'm very glad we've done, is we put links in the CPOE order sets that you could quickly put comments in and ask either for orders to be added or for enhancements or whatever else. That goes into an email queue that gets distributed to a group of folks that meet weekly that looks at those requests, and we pretty much use an 80-20 rule. If we think that 80% of the people would use it, we'll put it in the order set as long as it's evidence-based, or as long as there's no evidence against it, I guess is probably a better way to say. And so that's generally the approach we've taken. So it's a little bit of a, you either put up or shut up. It's sort of that approach. But on the other hand, we do ask for input, and we do listen to that input, and we do act upon that input as well as we can. That's on the inpatient side. On the outpatient side, we generally have asked for volunteers, folks that are interested in certain disease conditions. We tend to use a physician champion to lead that, and then I, as the de facto quality physician, try to go ahead and support that person in that committee. And we just work until we get consensus, and then we try to embed that into the forms. That makes it sound like it's easy. It's not. The diabetes process to get that pathway together took several months. So.
You did well.
Great. Great. And probably maybe one more brief question here, and there's probably a few others that we can maybe follow up with both of you offline to make sure we address. But there's a question about where is Riverside on the path to meaningful use and using your evidence-based order sets and plans of care to support that.
Right. From a meaningful use standpoint, we were one of the first organizations in the country to get meaningful use, first in Virginia, and before that, and again, it took a little while, but all the medical executive committees at our hospital basically made CPOE use mandatory. So from that ordering piece of meaningful use, that was kind of a done deal. We have about 90% of our orders go in electronically. The other 10%, a lot of that is actually the way you count them, and a lot of it is where like pharmacists have to revise an order, and I think we're still trying to figure out exactly is that CPOE or not. But suffice to say, we have pretty high CPOE rates, so we had no problem meeting the meaningful use standard for CPOE. Same thing on the outpatient side, although, as you know, in stage 1 it was only looking at medication orders, and we had been using e-prescribing for quite a while.
Great, thank you. Well, I think given that we're at the top of the hour here, I just wanted to thank both of you again for sharing and all of your great information around your innovative strategies. I think all of us learned a lot, and thank everyone for joining us. And Matt, I'll turn it back over to you.
Thank you, Michelle. As Michelle mentioned, unfortunately, we are out of time for today's presentation. I would also like to thank everyone for joining us. Once again, a special thanks to our presenters for today's fantastic webinar. One final reminder, for those interested, please visit www.ihealthtran.com to download today's recorded webinar and PowerPoint slides. Those will be up by close of business today. With that said, we wish everyone a fantastic day, and we look forward to connecting again in the future. Thank you so much.
Thank you.
Thank you.